They have 364 registrants today.
Wow.
So
Hello, welcome everybody.
Hi.
Thank you all for joining us. I have a few housekeeping announcements before we get started. So just on the behalf of the California Labor Lab, a NIOSH Center of Excellence for Total Worker Health, we are so pleased to welcome you today. Just to let you know, you are going to be muted during this presentation. So if you'd like to ask a question, we welcome you to enter it into the Q&A box. And a note that the Q&A is a different place than the chat. Putting it in the Q&A, make sure that we keep that question available in case folks are using the chat for other means. That way your question doesn't get buried. So we definitely invite you to go ahead and put that question in the Q&A box. This presentation is also being recorded and will be made available on the California Labor Lab and Center for Occupational and Environmental Health YouTube page in the next 5 business days. And all participants who logged in today with their registration email for the full live presentation will get an email tomorrow with a link to the evaluation form, and that'll qualify you for a certificate of completion worth 1 continuing education contact hour. So once you've complete your evaluation, you'll be able to access and print your certificate. That is it for my housekeeping announcements. Now I'm going to hand it over to Dr. Ed Yellen to welcome you all and introduce our speakers.
Great. Thank you so much for attending. And there are several hundred of you, I understand, who are registered. So that's fantastic. California Labor Lab, which is one of, as Michelle said, one of the NIOSH funded centers of excellence for total worker health. Ours is focused on the health impacts of emerging working conditions. And this project that you'll hear described today is certainly hits the spot perfectly for that issue, because many of the people who work in this industry, both the entrepreneurs and the workers, are immigrants, and also many of them work in alternative ways of being hired as independent contractors and the like. So it hits all the keynotes for our center. And I'm going to now introduce our 2 speakers, reading short bios of them, and then I'll turn it over to one of them, Bob Harrison, to proceed. So Kristin Cummings, who's an MD and PH, received her undergraduate degrees from Harvard University and public health and medical degrees from Johns Hopkins. She trained in internal medicine at Stanford University. We won't hold that against her. And occupational medicine at West Virginia University. She's certified by the American Board of Internal Medicine and the American Board of Preventive Medicine. In 2005, she joined CDC as an epidemic intelligence service officer assigned to NIOSH in Morgantown, West Virginia, later serving as a medical officer and field studies branch chief in NIOSH's respiratory health division. Dr. Cummings currently serves as chief of the occupational health branch of the California Department of Public Health. And we love that as part of the California Labor Lab, we have this alliance with State Department of Public Health. Bob Harrison joined UCSF in 1984. He founded and directed UCSF Occupational Health Services for more than 15 years and is now a senior attending physician and clinical professor of medicine. He has diagnosed and treated thousands of patients with work and environmental induced diseases and injuries. He's also chief of the Occupational Health Surveillance and Evaluation Program in the Occupational Health Branch of the California Department of Public Health. And I should add, a long-term friend of mine. So Bob, without further ado, and thank you both for both the project and for your report on it.
Thanks very much. Kristin, you're going to start the slide share, and I'm going to advance the slides. I'm going to do the first half and then turn it over to Kristin for the second. I see many colleagues around the country and in California on the chat. So many of you I know something about this issue. For those of you who I don't recognize, I hope that you'll become a lot more aware of this epidemic that we've uncovered in California of really severe silicosis caused by engineered stone. One of our close collaborators, I see Dr. Fazio was on the phone, and she's a lead author of an August 2023 publication in JAMA that I'm going to mention. Jennifer Flattery, who's a collaborator at the California Department of Public Health, and several others. So this has really been a very large joint effort by many, many colleagues. Next slide. I always like to start with faces and people when I talk about silicosis and what's happening with this in California. On the left-hand side is Juan Gonzalez, and on the right is Gustavo Reyes. Juan and Gustavo were featured in stories by Public Health Watch, which came out in December of last year. And at the time of these photos, both were waiting for a lung transplant. Gustavo on the right received his lung transplant and is fortunately doing very well right now. But unfortunately, Juan passed away in the intensive care unit before a donor lung became available. And he left behind 4 young children. I just talked last weekend with the daughter of a similar individual who is waiting for a lung transplant and unfortunately is having insurance problems and may not be eligible because his lung disease is so severe. Next slide. So I want to show you some slides with background on silica, silicosis, and engineered stone. Next slide. Respirable crystalline silica makes up 10% of the Earth's crust. So it's a very, very common mineral. And we've known literally for hundreds of years that silica dust, crystalline silica dust in particular, causes silicosis. In modern times, it's contained in rock, concrete, masonry, silica sand, and there are many, many occupations at risk, including drilling, cutting, sandblasting, demolition, and mining. Next slide. Silicosis was written about by one of the founders of the field of occupational medicine, Bernardino Ramazzini, who was born in 1633. In the 1930s, there was a very tragic disaster called Hawks Nest Tunnel, where workers were blasting a tunnel for water supply in West Virginia. And over 100 workers died of acute silicosis. They had developed a very disabling respiratory disease. There were congressional hearings that estimated that the death toll between 1930 and 1935 was over 470 workers, although later estimates upped it between 700 and 2,000. The features of the Hawks Nest disaster was rapidly progressive disease, which in my practice of occupational medicine, which started in the early 1980s, I had never seen, honestly, until the problem with engineered stone. Next slide. Respirable crystalline silica causes damage because of the relatively small particle size that reach the far reaches of the lung. Next slide. And you can see it gets into the very small air sacs or alveoli. Next slide. Where it causes lung inflammation and scarring of the lung tissue. And over time, this can lead to respiratory failure and eventually death. Next slide. So that disease is called silicosis. Chronic silicosis generally starts after about 10 years of exposure at relatively low concentrations of silica dust. Chronic is also called sometimes simple silicosis. Accelerated silicosis causes a similar lung scarring, but develops much more quickly, presumably in response to higher concentrations of silica dust. And acute silicosis is thought to develop weeks to years after very high silica exposure. Silica is toxic to the macrophages. These are the immune system cells that arrive after there's inflammation. And so because of that, workers with silicosis are predisposed to microbacterial infections such as tuberculosis, as well as fungal infections. In addition, silica dust is a risk factor for lung cancer, chronic obstructive pulmonary disease, a number of different autoimmune diseases, and chronic kidney disease. Next slide. On the left, you can see a chest X-ray of a patient with healthy lungs, and on the right is a patient with silicosis. You can see on the right in the silicosis patient, these white blotchy areas. This is the density caused by scarring of the lung tissue. Okay, so let's talk countertops. So here's a beautiful modern kitchen that appears to be made at first glance. You could say this is made out of white marble, but in fact, this is made from engineered stone that's made to look like marble. Next slide. So engineered stone has really captured the majority of the countertop market in the United States and in many other countries. Countertops made of engineered stone are durable. They come in a range of many different colors and patterns, and you can get them widely in big box stores, in tile and marble showrooms. And since the 1980s, the demand and the sales of this has exploded. Next slide. So what's the problem with engineered stone? Engineered stone is made of almost all silica sand. It's very fine, powdered silica sand that's mixed with an epoxy resin binder that's then poured into large molds, and it's put under vacuum, it's heated, the polyester resin hardens that stone, and when it's cooled, it's then polished by large machines, and it really becomes a fabulous surface for countertops. It's stain resistant, chip resistant, comes in a huge variety of different colors. Next slide. So what have we found in California? Next slide. Well, the first cases of silicosis from engineered stone were first reported in Spain in 2010, and then a larger case series in Israel that was reported in 2012. There were 25 cases of severe silicosis requiring lung transplant reported by a major medical center in Israel. Since then, it's become clear that this is a global epidemic among countertop fabrication workers. You can see that includes China and Australia. Australia has reported several hundred cases of severe silicosis many requiring lung transplant. And in China, reports really from one city found over 100 workers with severe silicosis from what was described as informal countertop fabrication shops. Next slide. So that prompted the California Department of Public Health, where I work, to begin looking for cases in California. We started by looking at hospital discharge data. Every time somebody's in the hospital, they get a diagnostic code. And we were looking for silicosis in younger patients, thinking that if somebody was young and had silicosis and was in the hospital, they were probably exposed to engineered stone. In January of 2019, my colleague Jennifer Flattery, who's on the webinar today, found a case of hospitalized silicosis in a relatively young man. He was 37, and he had started working in a stone fabrication shop in 2004. Next slide. He was first diagnosed with silicosis and scleroderma, which is an autoimmune disease caused by silicosis. And in 2017, he started to get worse, and he was hospitalized in 2017, which was how we found his case in early 2019. Next slide. Unfortunately, his case became so severe when he was referred in January of 2018 for a lung transplant. He was not eligible, and he died in September of 2018 of accelerated silicosis. Next slide. And that's how we found him in January of 2019. Next slide. So in follow-up, we conducted a workplace investigation with Cal OSHA. We found 2 additional cases, including another fatality, and all were young Hispanic immigrants in their 30s. Next slide. In the same workplace, chest X-ray screening of the current employees found 5 additional cases with a prevalence of 12% in this one workplace. The median age of the cases in that workplace was just 37. Next slide. We then expanded our surveillance efforts. We continued to review hospital discharge data, looking for the diagnosis code of silicosis among young individuals, receiving reports from doctors and attorneys. We used the NIOSH surveillance case definition, along with a history of engineered stone exposure. That case definition requires a history of exposure to airborne silica dust, a chest X-ray or a CT finding of silicosis, or a pathological finding of silicosis, a lung biopsy. Next slide. So to this point, we've identified a total of 93 cases and 10 deaths, and this is up to date within the last couple of weeks. Next slide. So let me turn to some of the clinical features, and again, I owe much of this to colleagues, including Dr. Fazio, who's on the phone, who's on the webinar. Next slide. So this is published in August in the Journal of the American Medical Association, and reports the first 52 cases. And you can see that the first case actually dates back to as early as 2010, although that was as a result of retrospective case finding when we pulled the hospitalized records and we got the additional medical records, obtained more information about the history. In fact, the person was diagnosed initially in 2010, and you can see the rapidly rising number of cases through August, through 2022. Next slide. Of significance, the median age was 45, which is very young for silicosis. All were men and all but one were Latino, and they were mostly from Mexico and El Salvador. Next slide. 85% of the cases were symptomatic at the time they were diagnosed, most commonly reporting cough and shortness of breath. Next slide. Their median work tenure was 15 years. A quarter continued working after they were diagnosed. Less than half reported that they used methods where water was sprayed on the product, which can keep down dust. Most reported only sometimes using a respirator, and half had worked in very small shops. So as I think Kristin will comment later, some of the policy challenges here is that in California and nationwide, most workers are working in relatively small shops, maybe between 5 and 10 employees. Next slide. A really concerning finding was that of the 52 cases, 30 or over half had a delay in diagnosis, probably due to difficulty by their healthcare providers in recognizing the disease. And the most common alternative initial diagnosis was tuberculosis. Next slide. Of the 52 cases, 6 had autoimmune disease, most commonly rheumatoid arthritis, and 5 had non-tuberculosis mycobacterial infection, and 1 had tuberculosis. Next slide. Simple silicosis was present in 61%, with very small nodular areas of fibrosis. You can see on this left, these little tiny dots are the little areas of scarring, but 38% had complicated or progressive massive fibrosis with very, very large areas of scarring, with these large areas of fibrosis or scarring greater than 1 centimeter. Next slide. In our case series, the case fatality rate was 19%, and the median time from diagnosis to death was 35 months, and the median age at death was 46 years. About 1 in 5, 21%, had to be referred for lung transplant, and 3 had undergone transplant at the time this report was published. Next slide. The majority of these cases are uninsured or underinsured. The number that had filed for workers' compensation was very low. You can see 7 out of those 52. And that was likely because many were working in informal working arrangements. They were working as independent contractors or they weren't aware that they could file for workers' compensation, or they were afraid to file a claim. Next slide. So is this the tip of the iceberg? We think probably it is. You can see on the map that there's a right, you can see the heat map of the shop locations in the state of California, with hotspots in LA County, Orange County, San Diego, and the Bay Area. We think there are at least 800 shops in the state, but that may be actually a substantial underestimate, as many shops are part of this informal economy and don't make it into official statistics or registries of formal employers. Next slide. So how many cases actually are there out there in the United States? If we use official Government Bureau of Labor Statistics figures, we estimate that there are close to 9,000 countertop fabrication shops and 100,000 workers in the industry. Lots of workers at risk. Next slide. Next slide. So you can see here the prevalence. We estimate between 12 and 20,000 workers with silicosis in the United States. Next slide. So I'm going to turn it over to Kristin to talk about the work that we've been doing, the policy, and the regulatory responses. Take it away, Kristin.
Thanks, Bob. So as it happens, federal OSHA introduced a new silica rule in 2016, and that was adopted by Cal OSHA, which is the state program here in California. The new rule lowered the exposure limit for respirable crystalline silica several-fold to 50 micrograms per cubic meter and added an action level of 25 micrograms per cubic meter. And the rule also introduced requirements for exposure monitoring, specified exposure controls, including respirators, required worker training, and added medical surveillance at baseline and every 3 years. That includes chest x-ray, spirometry, and baseline testing for tuberculosis. And this rule applies to all general industry with silica exposures, not just countertop fabrication. So this photo depicts workplace controls that should be in place to reduce silica exposures during countertop fabrication. These include engineering controls like the wet methods and local exhaust ventilation that you see there, administrative controls such as worker training, and as well as personal protective equipment, including respirators. And if all employers in California were using these methods, we may not be seeing the severe disease in young workers that we are seeing. But in contrast, this photo from Australia depicts the conditions in many California shops. The worker is dry cutting, which generates very high silica levels. Local exhaust ventilation is lacking, as is respiratory protection, and it's likely this worker has not received training about the hazards of engineered stone. Working in such dusty conditions poses a high risk of developing silicosis. And so that brings us to Cal OSHA and their activities to address the epidemic. And as I mentioned earlier, the silica standard set a permissible exposure limit of 50 micrograms per cubic meter. It also set an action level of 25 micrograms per cubic meter, which prompts exposure and medical monitoring. So in response to the detection of silicosis cases among countertop fabrication workers in California, Cal OSHA began an initiative called the Special Emphasis Program, or SEP, in 2019. And they identified workplaces throughout the state that used engineered stone to fabricate countertops. During the SEP, they opened inspections in 106 of these workplaces, and personal air sampling had been performed at 47 of them by the time the SEP was paused in 2020 because of the COVID pandemic. So this graph shows our analysis of the air sampling results. On the y-axis is the employee's silica exposure averaged over a full 8-hour shift. There are dashed lines at 25 and 50 micrograms representing the action level and the PAL respectively. Each tick on the x-axis represents one of the 47 inspected workplaces with air sampling results arranged in descending order of their highest employee exposure. And each dot is an employee silica exposure measurement. There are 152 in total. The purple dots are exposures above the PAL. The orange dots are exposures between the action level and the PAL, and the green dots indicate exposures below the action level. So among all 47 workplaces, as I said, there were 152 personal samples collected, and 51% of the workplaces sampled had at least one exposure above the PAL. And you can see some of these exposures were extremely high. The one towards the top left there is almost 700 micrograms per cubic meter, so many times the accepted exposure limit. So during the SEP, Cal OSHA inspectors administered a questionnaire that was developed in partnership with our branch. They conducted a total of 92 interviews. And we found that the interviewed workers were young with relatively short tenure in the industry. Many were Spanish speaking, and nearly all reported performing dust generating tasks, and about a quarter reported using dry methods. Most hadn't been informed of any air sampling results by their employer, and few had been fit tested for a respirator or offered a medical examination. So 72% of the employers were cited for violations of the silica standard, most commonly for the sections related to employer obligations to perform exposure assessments, communicate silica hazards to employees, and perform medical surveillance for employees exposed above the action level. 57% of employers were cited for violation of the respiratory protection standard, most commonly for the sections related to employer obligations to implement a respiratory protection program, perform fit testing, and perform medical evaluation to determine an employee's eligibility to use a respirator. So what are the next steps? This scenario poses quite a few challenges to prevention in multiple domains. And given what you've heard so far, wondering what you as a group think about the challenges in terms of the product, the industry, workers, clinicians, public health, and regulators. And I invite you to put your ideas in the chat. Okay, well, I'll go on and share. I hope you can all hear me okay. I'll go on and share the ideas that we came up with, which this is not meant to be an exhaustive list by any means, but one of the areas where the product is challenging is that it's so widely available and popular. As Bob mentioned, it really dominates the market now. And because it's toxic to fabricators and not to consumers, and I want to be clear here that I'm not saying, that we would want it to be toxic to consumers, but the point I'm trying to make is that when there's a harm to workers that's not affecting the general public, it can be harder to mobilize momentum and to advocate for change. In terms of the industry, it's global, it's very decentralized. As Bob mentioned, many of these shops are small, so that makes it more challenging to prevent, to get messages out. The workers are not unionized, they're socioeconomically vulnerable, and so oftentimes they may not want to come forward or report concerns. We described what is the largest outbreak of silicosis related to engineered stone in the United States right now, and yet this is still a pretty rare disease. As Bob mentioned, even someone with a tremendous amount of clinical experience may not have had the opportunity to diagnose this disease in the past, and so clinicians may not be familiar with silicosis. They certainly may not be thinking about it in people who are in their 30s. And then another piece of that is that they may not know who to report to and if they do make a diagnosis. On the public health side, we've found that our surveillance tools are limited. You heard about identifying a case through discharge records, and there are some challenges there. We're hearing about cases quite late in the disease process because those patients have to be sick enough to be hospitalized to get into that system. And there are challenges to outreach. And then finally, in terms of regulators, the regulators are limited in the sense that their citations may not have the intended impact. And to date, there are no limits on the sale or use of this material in California. So given these challenges, we have really tried to take a multidisciplinary approach to prevention that includes disease surveillance by public health and clinicians, workplace enforcement by CalOSHA, product stewardship by industry and government, education and support by a number of different entities, including regulator, public health, and universities. And then consumer awareness, which the media has actually been doing quite a good job of informing the public about this problem. So I want to talk a little bit about the project that we developed to respond to this epidemic. And this is what we call the California Artificial Stone and Silicosis Project, which is part of the California Labor Laboratory and funded by NIOSH. The project began in 2021. It's a 5-year project in which we aim to educate employers and workers, support early diagnosis of silicosis, and enhance public health surveillance. To date, we've developed educational materials for workers and employers. We're working with the LA County Department of Public Health and a local community organization in LA to conduct outreach there, which is important because many of the cases to date have been identified in LA County. And we're also working to increase awareness among healthcare providers. We published a fact sheet on our website, recently sent out an advisory using the California Health Alert Network, which goes to local health departments, providers, and hospital systems. We are finalizing a continuing medical education course and have presented at multiple forums to reach healthcare providers, including this month's California Medical Association Grand Rounds. As part of the CASS study, we're conducting a screening study in collaboration with Olive View UCLA Medical Center. Current countertop fabrication workers who live in LA County are eligible, and they will complete an interviewer-administered questionnaire and undergo standard screening with chest X-ray and spirometry, as well as enhanced screening with a chest CT and full pulmonary function tests, and they will also provide a blood sample for biomarkers of early silicosis. We have been exploring new surveillance tools to better capture the full burden of disease in the state. The Reportable Conditions Knowledge Management System, or RCKMS, is a newly launched system that facilitates automated case reporting to public health agencies via the electronic health record. We've been piloting this system for the past 9 months or so for silicosis case reporting in California, and that's been successful, and we are working on expanding that now. In addition, we are adding silicosis to Title 17, the list of reportable diseases and conditions, so that healthcare providers will be required to report cases of silicosis to public health in the future. And we expect that to go into effect in early 2024. And I should mention that all the provider reporting that's happened to date has been voluntary. So one of the impacts of our work is that CalOSHA has proposed emergency changes to the current silica standard. These include defining high exposure trigger tasks that will require exposure monitoring, use of wet methods without exception, and the use of full face powered air purifying respirators, so much higher level of respiratory protection than is currently required. The changes also include the addition of an imminent hazards clause that will allow CalOSHA to issue what's called an order prohibiting use. Effectively, this is a mechanism to shut down engineered stone fabrication at non-compliant shops. And the standards board that oversees CalOSHA's regulatory process will be voting on these emergency changes in a few weeks at their next meeting. So you're probably familiar with the hierarchy of controls, which lists the potential ways to control a hazard from most effective to least effective. And there's one very obvious control that we haven't really discussed yet, and that is elimination. So is anyone talking about eliminating what one colleague referred to as a fashion item, that this material is not essential, and rather really is a piece of fashion. Well, Australia is leading the way here. They conducted the most comprehensive screening of workers in this industry, of any that I know. Since 2015, they've identified on the order of 600 cases and found that with chest CT, the prevalence of disease is 25% or higher. They established a national dust disease task force, which issued a final report that you see here on the left. And in that report, the task force recommended a full ban by July 2024 if there were no improvements in compliance or if preventive measures proved ineffective. And since then, multiple stakeholders, including professional societies, the National Health and Safety Regulator, and the construction trade unions in Australia have endorsed the idea of a ban. And closer to home, in June, the LA County Board of Supervisors passed a motion on silicosis prevention and care in LA County. In addition to proclaiming the month of June as Silicosis Awareness Month, they instructed multiple county agencies to report back on the feasibility of banning the sale, fabrication, and installation of engineered stone in the county. And finally, we don't always think of the tort system as a public health tool, but it can be a powerful mechanism for promoting change in the workplace. And multiple lawsuits have now been filed in California by workers or their survivors against the manufacturers of engineered stone for toxic injuries, claiming negligence and fraudulent concealment. And those are working their way through the court. We don't know what the outcome will be. So this work has really required a tremendous amount of collaboration. So I want to thank my colleagues at CDPH, all of you UCLA and UCSF for their invaluable contributions. And in particular, I want to point out Dr. Jane Fazio, who's pictured here with her patient, Gustavo Reyes, who you saw at the beginning, looking healthy here after his lung transplant. And thanks so much for your attention. We'd be happy to take questions.
So, and it's a good thing that you left a lot of time for questions, because there are a lot of questions that have been asked. What a wonderful presentation. And I should just add that when we did our kitchen 10 years ago with Caesar stone, little did we know that we were contributing to this problem. So I don't think I'll be alive long enough to do our kitchen again, but if we do, we won't use Caesar stone. So without further ado, I'm going to go in the order of the questions that have been filed. The first is more comments from some in the audience. And they suggested the audience may be interested in the silicon control tool in Canada from British Columbia and Ontario. And they put that in the question and answer. And one of us should copy it into the chat so others can have it available if it's not there already. The second question I'll read. With regard to toxicological mechanisms, consider a single 3-micron diameter silica particle with some mass versus 1,000 0.3 micron diameter particles with the same total mass. When deposited in the alveolar region, do the 1,000 0.3 micron particles do more damage than the single 3-micron particle?
Kristin, you want to comment on the research papers on particle size distribution? There have been a couple.
Yeah, there have. I'm not sure that I can answer this question specifically, but I will say that one of the concerns about this product is that there does seem to be a different size distribution of the particles with engineered stone as opposed to more traditional natural stones. And the concern there is that the particles are smaller with the engineered stone. And that raises the concern that they could get it into the deeper lung more readily and potentially be absorbed more quickly. So I do think that particle size is definitely a concern here.
So the next question is engineered stone and quartz of same or similar composition?
A great question. The product known as engineered stone goes actually by a lot of different names. One of the names, which is really confusing, is that it can be called quartz or quartzite, which is actually an artificial engineered product. But if you buy quartz itself, it was just, like you've just bought like a quartz countertop, that's a natural stone that has a lower silica content. And I can't remember, it's less than 50%. Kristin, am I right? I'm just trying to remember what the quartz
I think you're
content.
right that it is very confusing, the terminology here. I think when you go into a shop and you're picking out your countertop, if they say quartz, they probably mean engineered stone. That's kind of the link that's used. Engineered stone, artificial stone, agglomerated, there's a number of different terms. But the idea being that the common term being used nowadays for this material is quartz. Quartz is also a form of silica found, that's found naturally and used to make this engineered stone. So it is confusing.
So
But you could also buy like a natural quartz countertop that's available on the market. It's not very common. But I totally agree with you, Kristin. If you go into a showroom and the salesperson shows you around, they might use the word quartz, but it's going to be an engineered product.
So the next question asker actually also put into the question and answer a regulation from EPA, the URL for the document. So hopefully that will be transferred to the chat so others can see it as well. The question is, employers have asked why it takes so long for silicosis to be diagnosed. The common answer has been that since this is a rare disease, the medical professionals are not familiar with initial symptoms. A similar gap was identified by EPA in regards to diseases related to pesticide, and that's the link. EPA has issued an RFI on the design of the healthcare training program. Would it be possible to do something similar for silicosis?
I think this is a really interesting point. I think the delay in diagnosing silicosis is kind of twofold. One is that there is a latency. So from the time of exposure to the time of disease onset is typically years. What we're seeing with this exposure to engineered stone is that latency period is shorter than we recognize for other types of silica exposures in construction and mining and such. So there is that latency period. And in fact, we've thought about the fact that the exposures, the cases that we're seeing now really reflect exposures that happened some years ago. And if we were to completely stop all exposures related to engineered stone today, we would still be seeing cases from exposures that happened in the past. So there's that latency piece, and then there is the issue around awareness among medical professionals, and that's something that we've been trying to address, as I said, in a number of different ways by increasing knowledge around this problem and how to diagnose.
The next question is, how do you address that even the most current OSHA silica standards is designed to address normal silica fibers rather than the extreme volume / nano-sized particles that are in engineered stone?
Bob, would you like me to take that?
Yeah,
one?
go ahead, Kristin.
Okay. I think this is another real challenge, and the fact that we have a silica standard that just came into effect in 2016 and really was considered one that would be very protective is it is discouraging to see the disease that's happening despite that very comprehensive standard. And so I think you're right that sometimes new parameters have to be considered. There's a new product now, and I think the standard that was written wasn't necessarily intended for this product, and I really give Cal OSHA a lot of credit for responding by saying, how can we modify this standard to make it more effective for this new exposure that's happening. And a couple of the ways that they're doing that is the current standard really requires or relies on air sampling to prompt a lot of other protective measures. And so one of the key changes in this new standard is to say just the very act of disrupting the surface of this material, and they have a long list of verbs: polishing, grinding, cutting. The act of doing that task is what prompts the protective measures rather than air samples. In other words, the new standard that will be voted on in a few weeks, that's really going under the assumption that anytime you disturb this material, you are creating a hazardous exposure, and we don't need to measure it to prove that. So that there's that one piece that just using this material, cutting it and shaping it should prompt tasks, prompt protective measures, controls. And then the really key piece is that wet, the requirement for wet methods, regardless of the situation, because we know that using water will decrease the exposures. Will using water decrease the exposures enough to prevent disease? Well, that's where the other piece comes in, which is respiratory protection, and they're requiring one of the highest levels of respiratory protection that's out there, which is a powered air purifying respirator. So I think that those are the types of regulations that we need to address this new type of exposure with a different exposure parameters in terms of the particle size.
Great. So next question is, are there any trade associations that provide training and support for the engineered stone industry?
Yes.
Would you like to speak to that?
Yeah, sure. So first of all, let me make a distinction between the manufacturers and the fabricators. So there are probably worldwide between 50 and 100 manufacturers of this product. There are some common ones that sell in the United States. They go by brand names such as Caesar Stone, Silestone. Cosentino has several different products and so on. But there are also many companies that export from India and China into the United States. So those manufacturers, to my knowledge, do not have a trade association, at least not one that I've been able to identify to this point. Then there's the fabricators where the workers that we presented here are working. The fabricators, some of them, and I think from what I understand, is maybe 10 to 20% of the fabricators in the US are members of the Natural Stone Institute, which is the trade association of fabricators, and they have a training program. The Natural Stone Institute can certify a shop to be, a good business with good working conditions, including silica controls. And there are, I don't want to speak for the trade association precisely, but I think there's 100+ certified shops in the United States. So it's only a small fraction of the total fabricators in the United States who have gone through the certification program. The certification program probably means that the working conditions are much better if they've signed up and have gone through this training with the Natural Stone Institute.
So we have about 8 or 9 minutes, and there are about 8 or 9 more questions. This has been extremely popular, a well-attended conference, and a very active group of people in the audience, which is great. So the next question is, without testing bulk materials for silica content, is there a way to differentiate artificial stone from natural stone, for parentheses, granite, quartz, marble? Are there trade names associated with artificial stone and appearance differences?
I'll take a first stab. Kristin, you can add. Yeah, there are definitely trade names and many different products. And from a consumer perspective, I would say just ask, right? Is this an artificial or an engineered product, or is this a natural product? And there are material safety data sheets that accompany all these products, and they have the percentage silica content. And so that's pretty easily available, you know, at least from a scientific and researcher's point of view. From a consumer also, do the appearances differ? I don't know. It's been a while since I've shopped for kitchen countertops. Probably. Although I have to say, one of the clusters of really severe silicosis cases in a relatively small shop in LA, many of the workers there were using a product that was sold as Italian-like design. And when I went onto the website of the company that was selling this Italian-like design, I discovered that the product was actually manufactured in India, and that the company had on their website a picture of Carrara marble in Italy, and said that the manager was of Italian descent. And if you looked at it, it looked like Italian Carrara marble. So I guess the answer is not perfect, you know, that it could look real, but really be artificial.
Moving on, I mean, we could go on forever given the number of questions, try and get through as many as possible. Somebody asks, why can we not ban cigarettes in addition? And that's a classic important point that the viewer made. Why don't we, they should be banned. So let's go to the next question. Based on the data collected from the project, what will be the next steps to prevent any further silica exposure to employees, to prevent further damage? If a ban of engineered stone only occurs in Australia and California, how will employee exposure be controlled in other countries like China, where regulations do not exist at all?
That's a really profound question. I hit the nail on the head. Kristin,
Right.
You want to pick up the hammer?
No, I agree. This is really one of the big challenges here, is how do we address this problem in a way that's comprehensive. And I think one of the other kind of a related challenge we're having now is that I see that there's a question about what have the manufacturers done. So one of the responses of the manufacturers very recently is that they have been promoting newer engineered stone materials that they call low silica, that have a much lower percentage silica. And I think, you know, as a knee-jerk response, that sounds terrific. Let's just encourage everyone to start using these alternative products that have low silica. And I think one of my concerns is, well, what have they replaced the silica with? You know, there are a couple questions as well about, you know, what is the health impact of the resin that binds the silica together. You know, there are a number of things that could be happening with these products. We know that silica is toxic and can do the things that we're seeing, but these, you know, organic resins release volatile organic chemicals and may also be having an impact on the lung. There are pigments that are used, many of which have metal in them. Could the metal also be causing harm to the lung? And then, you know, if these substitutes are introducing new materials that we don't really know the effects of. So I think it really is a challenge. But our responsibility here in California is to try to find a solution here in California. And we're taking inspiration from what they're doing in Australia. And I think if we can find a solution here, that could be replicated elsewhere.
Let me
So
just,
it's
Kristin, that I see some comments by our colleague Ryan Hoy from Australia,
Oh,
who
great.
has a link there. And I strongly encourage everybody to read the latest report with the recommendations from Australia to the parliament there, looking at a number of options policy-wise. And Ryan, if you're still on and you could easily put that link up to everybody, it was the one I think that came out 2 or 3 weeks ago. Really, really good summary.
well, and Kristin's comment was apropos because the next question, which she answered already, is the stuff used to stick the stone dust together to make engineered stone also bad for health? And you dealt with that one. The next question is related to the issue of, can a small jurisdiction affect the whole picture when there's an international market? And I'll read it. Does the action being considered by the LA County Board of Supervisors mean that such a ban or related action is unambiguously a county level issue? Could there be a state level ban or related policy? Has there been an industry pushback formulated to date against the ban?
Bob, would you like me
Sure.
to take that, or do you wanna go? Please.
I really can't comment very intelligibly about the legal aspects of whether a locality or a state can ban a product such as engineered stone. LA County, the Board of Supervisors, had voted in June to consider that as a policy option, suggesting to me that at least their legal review concluded that even a county could potentially ban or put a prohibition on use of a product within their borders, you know, in the areas that LA County regulates. You know, my preliminary discussions with attorneys are that, you know, a state can probably do something similar. Whether or not it would pass constitutional muster, I don't know, again, because I'm not an attorney. And again, you know, the government of Australia is debating that now, and I think has until June to make a decision. And they obviously have the legal authority to be able to do this, assuming that it's being debated in Parliament. I come back to manufacturer's responsibility and supply chain, because this is, I think, clearly a national problem. You know, I think Kristin and I are often asked, well, how come all these cases are just predominantly in California, right? You know, there are probably about 20 that we've identified elsewhere around the country. And I think there's a variety of reasons. I think access, clinician recognition, public health activities are at a level in California that we can identify all these cases. But what we do here in California, I think, has an impact, even at a locality level. The idea that a product is prohibited from use spurs action, particularly on the part of manufacturers who don't want to see their product prohibited from use. So my view is, even at the local level, any activity, any light that is shed on this has an impact elsewhere.
So
Ryan said decision 2 weeks.
So we are at the end of time. There are, since we started, an additional 6 or 7 questions. Is there a way of preserving them, Michelle, and having the speakers answer them after the webinar is over? Because
I can download the chat and the Q&A, and I'll be sure to share it with everyone.
great. And so we thank the speakers most of all. What a wonderful session. We also thank the audience for such a tremendous number of thoughtful questions, and we have 79 comments in the chat. So this issue just has tremendous resonance with the audience for the California Labor Labs webinar. One comment I will just pass on, one of the answers, askers gave a website that people can look at, and it's www.silica-safe.org. And it's a tool for exposure control planning. And that would be one thing that everybody on the call can do for themselves, their coworkers and colleagues to try and eradicate this tremendous problem. So again, thank you to the speakers and to the people who attended the California Labor Labs webinar this month. Goodbye.